Imagine going to sleep feeling completely normal and never waking up again. For thousands of seniors each year, that's exactly what happens. Medical experts say many of these cases are preventable, but only if the early warning signs are recognized in time, and most people miss them. Let's go through the signs that matter most. I want you to think about the last time you had a large dinner late in the evening. Maybe it was a family gathering. Maybe it was just a habit that developed over years of a busy schedule. Maybe late eating is simply how your household has always operated. I want to tell you what your cardiovascular system was doing while you slept that night. Because what happens inside the body of a senior who goes to bed within 2 to 3 hours of a heavy meal is something that most people have absolutely no awareness of, and the research behind it is genuinely alarming. Here is the mechanism. When you eat a large meal, your body redirects blood flow dramatically toward your digestive system, your stomach, your small intestine, your liver. These organs demand and receive a surge in blood supply to process what you have just consumed. In a younger body, the cardiovascular system handles this redistribution efficiently. The heart adjusts, the blood pressure compensates, the system stays balanced. After 75, that compensation becomes unreliable. Research published in the Journal of the American Geriatric Society has documented what cardiologists call postprandial hypotension, a drop in blood pressure that occurs after eating that affects up to 38% of community-dwelling seniors. In some patients, systolic blood pressure drops by 20, 30, even 40 points within 30 to 60 minutes of finishing a meal. Now take that blood pressure drop and add sleep. When you lie down, your blood pressure naturally decreases further as part of your body's overnight regulation. In a healthy senior, this nocturnal dip is normal and actually protective. But in a senior who already experienced postprandial hypotension from a late heavy meal, layering a normal nocturnal blood pressure drop on top of an already compromised baseline creates a window of dangerously low perfusion pressure, the pressure driving blood to your brain and your heart. Dangerously low perfusion pressure to the brain during sleep is one of the primary mechanisms behind nocturnal ischemic stroke. The brain, receiving inadequate blood flow during the hours it is supposed to be consolidating memory and repairing tissue, instead experiences localized oxygen deprivation. Sometimes this causes a full stroke. Sometimes it causes what researchers call a silent stroke, an event the patient never consciously experiences, but that shows up on MRI as a lesion. Silent strokes accumulate. They compound. They are directly linked to dementia progression and to elevated risk of a subsequent major stroke. The cardiac side of this equation is equally serious. Your heart itself is a muscle. It requires continuous blood supply through the coronary arteries. When perfusion pressure drops significantly during sleep, the coronary arteries, particularly in a senior who has any degree of atherosclerosis, any narrowing of those vessels, may not deliver adequate oxygen to the heart muscle. This is the mechanism behind nocturnal angina and nocturnal myocardial infarction, a heart attack that begins not from exertion, not from stress, but from the simple physiological consequence of inadequate blood supply to heart tissue during sleep. And the meal itself adds another layer. A heavy meal high in saturated fat triggers an acute inflammatory response in the bloodstream. Research published in the journal Atherosclerosis has documented that triglyceride levels in the blood spike dramatically in the 2 to 4 hours following a high-fat meal. Elevated triglycerides thicken the blood. Thickened blood in vessels that are already narrowed by years of atherosclerosis is a clot waiting to form. I need to address something that an enormous percentage of seniors across this country have decided is simply a fact of getting older, something they have stopped mentioning to their doctors, something their families have normalized, something that has been folded so completely into the accepted experience of aging that raising it as a medical concern feels almost unnecessary. Getting up 2, 3, 4 times a night to urinate is not normal. It is a symptom, and in seniors it is frequently a symptom of a cardiovascular condition that is operating silently during the day and revealing itself at night in the only way it can. Let me explain the mechanism, because it is one of the most important pieces of cardiovascular physiology that almost no patient over 70 has ever been told. The condition is called nocturnal polyuria, excessive urine production during nighttime hours, and in seniors it is frequently driven not by bladder problems and not by drinking too much water before bed, but by the heart, specifically by a heart that is not pumping efficiently enough during the day to prevent fluid from pooling in the lower extremities. When a senior with early or moderate heart failure sits or stands during the day, gravity pulls fluid that is leaking out of blood vessels due to elevated venous pressure from a struggling heart into the legs and feet. This is why so many seniors with undiagnosed heart failure notice ankle swelling by the end of the day. They assume it is arthritis. They assume it is inactivity. They elevate their feet for a while and it seems to help, so they stop worrying about it. But here's what happens when they lie down at night. That fluid, no longer pulled downward by gravity, redistributes back into the circulatory system. The blood volume increases. The kidneys, detecting the increased volume, respond by producing more urine to eliminate the excess fluid. This is why the patient wakes up at 2 in the morning, and again at 4, and again at 5:30. Not because their bladder is the problem, but because their heart spent the entire day insufficiently managing their fluid balance, and the nighttime redistribution is the physiological consequence. The Framingham Heart Study, the most comprehensive long-term cardiovascular study ever conducted, identified nocturia, the medical term for nighttime urination, as an independent predictor of cardiovascular events in seniors. 2 or more episodes of nocturia per night in patients over 65 is associated with a 40% increased risk of cardiovascular hospitalization. That is not a minor statistical association. That is a significant documented signal that most seniors are receiving every single night and nobody is reading correctly. And the danger goes beyond what the nocturia itself indicates. Getting up repeatedly during the night to use the bathroom while groggy, disoriented, and in the vulnerable blood pressure state of interrupted sleep is one of the leading precipitating events for nocturnal falls. The National Council on Aging reports that nighttime falls account for a disproportionate share of the most serious fall-related injuries in seniors. Hip fractures, head injuries, injuries that for patients over 75 carry documented mortality risk within the following 12 months. The blood pressure piece is particularly dangerous. When you have been lying down sleeping and you stand up suddenly, your body needs to rapidly redirect blood upward against gravity to maintain adequate perfusion to your brain. This reflex, called orthostatic compensation, slows significantly with age. Research shows that after 75, the time required for the cardiovascular system to fully compensate for the blood pressure drop of standing increases by 40 to 60%. In the middle of the night, with sleep inertia affecting your neurological function and your cardiovascular system operating in its overnight low-pressure mode, that compensation is even slower. This is why so many seniors feel dizzy or lightheaded when they stand at night. And it is why so many of the falls that happen on the way to the bathroom at 3 in the morning are not about tripping over something. They are about a cardiovascular system that cannot redirect blood to the brain fast enough. This is the one that surprises my patients most, because back sleeping, for most of their lives, has been associated with comfort, with proper spinal alignment, with the position their doctor or their physical therapist told them was best for their back. And I am not here to tell you that back sleeping is universally wrong. But I am here to tell you that for a significant and specific subset of the senior population, back sleeping is directly triggering a cascade of cardiovascular events during the night that is elevating their heart attack and stroke risk in ways they have absolutely no awareness of. The mechanism is obstructive sleep apnea, and before you tell me you have already been tested and you do not have it, I need you to hear this. The American Academy of Sleep Medicine estimates that approximately 80% of moderate to severe sleep apnea cases in adults over 65 remain undiagnosed. 80%. Not because the condition is rare, but because the screening process is inadequate and because seniors have been told for so long that disrupted sleep is simply part of aging that they have stopped reporting the symptoms that would trigger a referral. Here is what obstructive sleep apnea does to your cardiovascular system during the night. When the muscles of your airway relax during sleep, and in the supine, flat on your back position, gravity pulls the tongue and soft palate directly backward into the airway partially or completely collapses. You stop breathing, your blood oxygen level drops. Your body detects the oxygen deprivation and triggers an emergency stress response. Cortisol and adrenaline flood your system. Your heart rate spikes. Your blood pressure surges. Your blood vessels constrict. Then you partially wake, the airway opens, you breathe again, and the cycle repeats. In a patient with moderate sleep apnea, this cycle repeats between 15 and 30 times per hour. In severe cases, more than 30 times per hour. The patient consciously remembers none of it. They think they slept through the night. Their cardiovascular system experienced 200 separate acute stress events. The research on what this does to the heart and brain over time is unambiguous. The Sleep Heart Health Study, a landmark NIH-funded research program following thousands of patients over years, documented that untreated obstructive sleep apnea in seniors is associated with a 140% increased risk of coronary artery disease, a 60% increased risk of stroke, and a significantly elevated risk of nocturnal cardiac arrhythmias, abnormal heart rhythms that occur specifically during the oxygen deprivation events and that can trigger sudden cardiac death during sleep. That last finding deserves to be said plainly. Untreated sleep apnea is a documented contributor to sudden cardiac death during sleep. This is not theoretical. This is in the peer-reviewed literature. The back-sleeping connection is critical because positional sleep apnea that is significantly worse in the supine position, is one of the most common presentations in older adults. Research published in the journal Chest documented that among patients with diagnosed sleep apnea, approximately 56% have positional apnea that is meaningfully more severe when sleeping on their back than when sleeping on their side. For these patients, positional therapy, simply changing from back sleeping to side sleeping, reduces apnea severity by 50 to 70% without any device, without any medication, without any procedure. What you do with this information starts tonight. If you snore, if your partner has ever told you that you stop breathing during the night, if you wake with headaches, if you feel unrefreshed after what should have been a full night of sleep, if you have high blood pressure that is difficult to control despite medication, every one of those is a documented symptom of undiagnosed sleep apnea. Ask your physician for a sleep study. Home sleep testing is now widely available. It does not require a night in a laboratory. And if sleep apnea is identified and treated, whether through CPAP therapy, positional therapy, a dental appliance, or another approach, the cardiovascular benefit is documented and significant. This is the finding that I wish every cardiologist in America would post in their waiting room, because it is supported by some of the most compelling cardiovascular outcome data published in the last decade. And it is information that the overwhelming majority of seniors who take blood pressure medication have never received. Most seniors who take antihypertensive medication, and that is the majority of Americans over 70, take it in the morning. They take it with breakfast. They take it when they take all their other pills in the routine they established when they first started the medication, following the instruction their doctor gave them years ago without specifically discussing timing. And for decades, morning dosing was the standard. It made intuitive sense. Blood pressure is higher during active daytime hours. Medicate during the day to control daytime pressure. But here is what the research that has accumulated over the last 15 years has conclusively shown. For a significant proportion of hypertensive patients, the most dangerous period of cardiovascular risk is not daytime. It is the early morning hours between 3 and 6 a.m., the period when blood pressure surges naturally as the body prepares to wake. This surge, called the morning blood pressure surge, is the period during which heart attack and stroke rates are highest across the entire 24-hour cycle. Research has documented that heart attacks are 40% more likely to occur between 6 and 10 a.m. than at any other time of day. And for patients whose blood pressure surges dramatically in those early morning hours, morning-dosed medication that was taken 18 to 20 hours earlier may have substantially worn off exactly when it is needed most. The landmark Hygia chronotherapy trial, published in the European Heart Journal and following more than 19,000 hypertensive patients over an average of 6 years, found that patients who took their antihypertensive medication at bedtime rather than in the morning experienced 45% fewer cardiovascular events, including heart attack, stroke, heart failure, and cardiovascular death, compared to patients who took the same medication in the morning. 45%. From timing alone, not from a new drug, not from a dosage increase, from when the existing medication was taken. The mechanism makes physiological sense. Bedtime dosing ensures that the medication is at or near peak effectiveness during the early morning surge hours when cardiovascular risk is highest. It also ensures that overnight blood pressure, which should naturally dip during sleep in a healthy cardiovascular system, is adequately controlled in patients whose nighttime pressure does not dip appropriately, a condition called non-dipping that is significantly more common in seniors and that is independently associated with elevated cardiovascular risk. What you do with this is simple but important. Do not change your medication timing without talking to your physician first. Some blood pressure medications, particularly diuretics that will cause you to urinate, are appropriately taken in the morning for practical reasons. The Hygia findings apply most strongly to certain classes of antihypertensive medications and may not be universal across all drug types. I told you at the beginning that I was saving the most important one for last, and I meant it, because this is not about a habit in the traditional sense. This is about a window of time, a specific, documented, physiologically critical window of time, during which your body is sending you signals that something is wrong with your heart or your brain. And the majority of seniors who receive those signals in that window dismiss them, go to sleep, and never wake up. The hour before sleep is when your body's physiological state is shifting. Your blood pressure is moving. Your heart rate is changing. Your autonomic nervous system is transitioning from sympathetic, the active, alert state, to parasympathetic, the rest and digest state. These transitions are normal. But in a senior with underlying cardiovascular disease that may be entirely undiagnosed, these transitions can unmask symptoms that are invisible during the noise of a busy, active day. Let me tell you what those symptoms are, because they are not the dramatic, unmistakable symptoms that everyone associates with heart attack and stroke. Those dramatic symptoms, crushing chest pain, sudden inability to speak, face drooping, arm paralysis, those are the late stage of an event that has been building. What I am talking about are the earlier, subtler signals that occur in the hour before sleep that most seniors explain away. The first is jaw pain or neck pain or upper back pain that appears in the evening without obvious cause. Not the chronic arthritis pain they have managed for years, a different quality of pain, unusual, pressure-like, something that feels vaguely off in a way that is hard to articulate. Research published in the journal Circulation has documented that atypical chest pain equivalents, pain in the jaw, neck, upper back, or shoulders, are more common presentations of cardiac ischemia in women and in seniors than the classic crushing chest pain that most people expect. These are the presentations that get dismissed as muscle tension or indigestion and result in patients going to sleep instead of calling for help. The second is an episode of sudden, unexplained shortness of breath while lying down or reclining to watch television in the evening. Orthopnea, difficulty breathing when flat, is a classic symptom of heart failure and pulmonary congestion. In a senior who has normalized mild breathlessness as a consequence of aging, the progression of this symptom often goes unrecognized until it is severe. The third is palpitations, an awareness of your heartbeat, a fluttering, a sense that your heart skipped or added a beat, occurring in the evening or at the time of lying down. The transition to the parasympathetic state at bedtime is a documented trigger for atrial fibrillation onset. Research has shown that atrial fibrillation episodes are more likely to begin in the evening and overnight hours in patients with paroxysmal or intermittent atrial fibrillation, atrial fibrillation that goes undetected because the patient dismissed the palpitation sensation, went to sleep, and had a stroke during the night from the clot that formed during the arrhythmia episode. The fourth, and this is the one that I find most heartbreaking in hindsight when I review what patients experienced in the hours before a nocturnal event, is an unusual and profound sense of fatigue or heaviness that feels qualitatively different from ordinary tiredness. Patients describe it in retrospect, through family members who heard them mention it, as a heaviness they could not explain, a sense that something was wrong that they could not name. The autonomic nervous system detects myocardial ischemia, inadequate oxygen supply to the heart muscle, before the patient consciously registers pain. It generates a systemic distress signal. That signal is experienced as profound unexplained fatigue, unease, or a vague sense of dread, and it is routinely dismissed as simply being tired at the end of the day. The fifth is a sudden, severe headache in the evening or at bedtime, particularly a headache that the patient describes as the worst headache of their life or a headache that is different in character from any previous headache. This is a documented warning sign of hemorrhagic stroke, bleeding in the brain, and it is a symptom that demands immediate emergency evaluation, not a sleep aid in bed.